Today is Breast Care Day at ECR, and I'm very pleased to have with me today Professor Christiane Kuhl, who was a participant in this day. Christiane, welcome to ECR.
Hi, hello.
Now, how did it go? How was the first day? How did Breast Care Day go for you?
Well, I think it was successful in that there was a large crowd of people. The room was packed. There was a vivid discussion even after the lectures, so I think it was a success.
Okay, good. It was an early session. Did that surprise you how well attended it was?
That's specifically because it was so early. I was quite surprised to see that many people in the audience.
Okay. Now, were there any surprises? Were there any questions that you weren't expecting?
No.
No? So you obviously prepared very well for it.
Well, I think they were quite natural to be expected. The questions that were asked were somehow to be expected.
I mean, what was uppermost on people's mind? What were they talking about?
Well, that's actually on how we should use abbreviated breast MRI. I think the concept to explain is that we just reduce the number of pulse sequences down to the very essence. So we have there are a lot of studies right now using or investigating the use of MRI for screening for breast cancer. The problem here is that the technology that we used so far is actually one that is meant to be used in a diagnostic situation where people use lengthy pulse sequence protocols to extract every little bit of information out of tissue to characterize disease or look at disease extent and things. Now, with screening, the vast majority of individuals who undergo the examination will be fine. They don't have disease. And only the ones that, the small number of women who do have breast cancer at the time of the screening examination can at all benefit from the screening. That reduces the cost-benefit ratio, of course, of any screening program, and if screening, the method that you use for screening is expensive, then the cost-benefit ratio is usually poor. Now, that's why currently we use MRI for screening only in a very selected population that usually is carries a high risk of breast cancer. And even these women, current statistics say that less than 1.5% of eligible women who do indeed have that strong family background do have access to breast MRI for screening. Okay,
so in terms of the patients, when they come to you at Aachen, how do you approach this? What sort of diagnostic workup do you take? And when would you involve MRI in your process in the workup?
Well, that's a difficult question to answer because right now there is no recommended place for MRI screening. A workup is actually a diagnostic situation. So a woman has a screening mammogram or maybe a screening ultrasound. If you find something suspicious, you may proceed to breast MRI for problem solving. This, however, is a completely different situation from a woman who, for one reason or another, chooses for herself to undergo the most sensitive test for breast cancer screening that is currently available.
Okay.
And the fact that right now we use MRI only for screening women at high risk of breast cancer is not for medical considerations, but mainly because the costs are so high. So it's actually a matter of economic cost allocation. Even women at high risk, as I said, don't have access to breast MRI, probably for cost reasons. The concept of abbreviated breast MRI is to reduce the number of pulse sequences down to the very essence, in that we just use one pre, one post contrast acquisition, then subtract, which yields the first post contrast subtracted images or fast images. Then we fuse the fast images into one maximum intensity projection, the MIP image. Now, the concept is to have expert readers review the MIP images to decide about presence or absence of enhancement, which takes a couple of seconds. And then, if there is enhancement, go to the first post-contrast subtracted images, or even the non-subtracted source images, to characterize enhancement. This is obviously done based on our research with a diagnostic accuracy that is very similar to the full multiparametric breast MRI protocol that we used so far for screening, with the difference being the fact that a woman is only for like 3 minutes in a magnet, and that reviewing the images takes a couple of seconds for radiologists, which will greatly reduce the costs that are associated with such an examination.
Very good. So it's a big change. How many patients have actually had this approach, the abbreviated approach?
Well, we published this on roughly 700 women, and since then we try to push this. And I know that there are a lot of sites right now that think about trying to integrate this into their protocol. In Aachen right now, we use this mainly in women who don't have insurance coverage for screening, and this is, of course, the majority of women, actually.
Okay. So in terms of publishing, will there be further studies, further research published over this year?
I mean, we are hopefully will start an ACRIN, American College of Radiology Imaging Network trial on the use of abbreviated breast MRI compared with breast tomosynthesis in women with dense breast tissue, and that is going to hopefully be up and running by next year.
Excellent. Do you feel, as a general rule, do you feel that industry is doing enough to promote breast MRI for screening purposes?
No. So far, no, I would say, although this is understandable, given the fact that breast MRI so far is greatly underused. I mean, again, this is a matter of cost, although it's not only cost. If you compare it to the utilization of MRI of the knee, the elbow, the shoulder, lumbar spine, there's a lot of, say, cost or financial resources that go into MR examinations, which by themselves don't actually make a big difference. Very much unlike MRI of the breast, not only, I mean, or mainly for treatment planning or for problem solving, and also for screening.
Okay.
I mean, right now there's a big discussion around overdiagnosis due to breast cancer screening. Although this is certainly a problem, specifically with mammographic screening, I think the real problem that we still face is underdiagnosis of breast cancer. And this is a simple proof to this fact is the fact that even today, breast cancer is the most important cancer killer in the female population. This hasn't changed in spite of decades of mammographic screening.
Yeah.
So this is our main problem.
So you're not too disturbed by studies from Denmark, from other countries, about the importance of overdiagnosis?
Well, I am disturbed, but I think that overdiagnosis is mainly a consequence of the fact that mammography per se depicts preferably slowly growing cancers. This is due to the fact that what we depict with mammography, if we want to diagnose cancer, are regressive changes, calcifications are due to cell death, necrosis or architectural distortions are due to hypoxia. And it's well established that a cancer that is picked up by mammographic screening, or a woman with a cancer that is picked up with mammographic screening, enjoys a better prognosis than a woman whose cancer was not picked up by mammographic screening. Another way of putting this is to say a breast cancer that is depictable by mammography has a better prognosis than a breast cancer that is occult on mammography. So I think that overdiagnosis is certainly a big problem in the entire field of screening. I think it's a specific or specifically important problem for mammographic screening.
Okay. Now, in terms of the future, do you still remain optimistic about breast MRI for screening purposes? Do you have the heart? Do you have still the passion very much for the subject? I know you have the passion. Do you have the hope and the optimism?
Well, I do. I mean, it took a while. Back, like in the 1990s, we described that MRI is useful for screening, specifically in the high-risk cohort, that we can triple the sensitivity of mammography. Then people argued, what about the specificity, false positive rate? Then we actually found that the specificity and false positive rate, or PPV, of MRI screening is actually higher than that of mammography in the same women. So solve this problem as well. Then people argued you can't diagnose DCIS with MRI, so you have to rely on mammography for this purpose. Then we proved them wrong and published that DCIS is indeed diagnosable with MRI screening. Now people said that, well, this is all way too expensive. And then we now introduced this abbreviated protocol. So I think now, for the latest, people should think about using MRI on a broader scale.
Good. Okay, so the future is good. We look forward to the publication of your additional studies, and we wish you all the best.
Thank you very much.